Great. Well, so thank you all for coming. This is a breakout session that we have our esteemed cardiac imagers here that will help us get through this. This is artificial intelligence for amyloid detection. And again, we have Dr. Jamal and Dr. Arsanjani, and they will be speaking on using AI in echocardiographic practice and developing multimodality or artificial intelligence with ECG, echo to identify cardiac amyloidosis. So this will be very interesting. So let's keep in touch.
Here we go. All right. So I'm going to start off primarily and introduce the use of artificial intelligence in review of echocardiography, and then Dr. Arsanjani is going to go into the use of AI to look at multiple modalities in in a combined approach. So again, talking about those populations that are at risk, where, as readers in an echo lab, we always look at what's the reason that this echo was ordered as we read it. So if the reason was HFpEF or aortic stenosis, we should have some concern for ATTR, and we should sort of be thinking about that as we read the echo. And then when it comes to myeloma, I'm thinking about AL in about 15% of those patients. So again, these are the populations where we're scrutinizing the echo a little bit more closely. If it looks like this, it's not, this is not exactly subtle, so it's not a problem. But the problem really is, it takes a long time for the echocardiogram to look like that. And so for that reason, cardiac amyloidosis is generally diagnosed late. And as echo readers, we feel like we're catching it early and pat ourselves on the back like, oh, I diagnosed this patient with cardiac amyloidosis just off of the echocardiogram. But the reality is that the disease is already advanced by the time that we see it. And then when you think about busy clinical practices in the community where they're reading a large volume of echocardiograms, the more subtle findings and subtle changes on echo may go missed. And then we've talked about the value of global longitudinal strain being a more novel parameter that can be very helpful in distinguishing cardiac amyloid, especially given that the disease really doesn't impair the ejection fraction. So the strength of the heart looks normal visually, but GLS can be very helpful in catching these patients, but it's not being utilized universally when you look at community practices across this nation. And then even when you look at more elementary measurements like simple wall thickness, it's not as straightforward as we all sort of think it to be. I think that most cardiologists in the room will agree that the wall thickness measured by the technician is different from what I will measure, and it might be different from what my colleague measures. And so there are differences there that present a challenge. And then there are subtle findings like just a little bit of wall thickening, a little bit of pericardial effusion, or reduced tissue velocities, and often these are overlooked, especially in the presence of a normal ejection fraction. So at our institution, we thought, how can we not miss these patients? What should we be doing on a systematic level across the organization to try to improve the diagnosis of cardiac amyloidosis? So one of the quality improvement projects that I undertook was instituting, so this was before we even looked at the echoes, we were thinking about our electronic medical record system, and I instituted an algorithm within Epic to identify patients who had moderate LV wall thickening, because we felt like these were patients that were suspects. And while Dr. Arsanjani certainly correctly mentioned that there can be many different reasons for LV wall thickening, but I would say that if you're, in general, the heart is a muscle, and if it's squeezing against a large load, then it will thicken, right? So what load would that be? That would be high blood pressure or aortic valve tightening. If the door is not opening, then it's going to be hard for the muscle to squeeze and it will thicken. So if you rule those two conditions out, then the next most common cause oftentimes becomes cardiac amyloid. In our patient population, we see a lot of AL as a cause of wall thickening in these patients who don't have hypertension or aortic stenosis. So what we did was we created this algorithm and we ran it across the EMR and identified several hundred patients who had increased wall thickness, then the gargantuan task was, okay, do we believe it? Because we're not going to work up hundreds of people for AL amyloid. So I actually went through and I had to go through every single echocardiogram and determine whether I agreed that the walls were thick or not. And it turns out a lot of time it's just erroneous measurement. And so it was a minority of patients that actually were true suspects. And then we referred them to our clinic to initiate an evaluation to look for amyloidosis. So the overall effort, even though this is a fairly simple project where we think that the EMR is going to help us and this can be automated, really it still requires a fair bit of effort to then review those patients. Thereafter, we did a study where we looked at novel parameters. I mentioned that we looked at left atrial strain in these patients, and that was another sort of effort to try to identify patients and screen them within our population and find cases of amyloid earlier. And so left atrial strain proved to be a parameter that can be used, but again, it's fairly non-specific. So not all of these patients are going to have amyloidosis, and across the board, this is not something that's being done really outside of research centers. And so overall, these projects in general have required a lot of effort, and clinicians have to study multiple echo parameters to then diagnose cardiac amyloidosis. The methodology has to be consistent, and ultimately the diagnosis is clinically complex. It's time consuming, and it can be really challenging in busy practice settings. So this is where AI really comes in and serves as a single solution to all these aforementioned issues, because it is something that can be run systematically on all of your echoes, and it's doing all of that work that I talked about. It's sort of looking at all of that, right? It's just doing it automatically. It's automatically looking at the wall thickness. It's looking at the movement of the left ventricle. It's looking at the left atrial and right ventricular strain. It's looking for effusions. It's looking at, it's a pattern recognition algorithm that's looking for patterns that are going to be consistent with cardiac amyloid. So this, when you run something like this, it's going to essentially significantly reduce reader effort, and imaging review becomes very systematic and consistent. So we worked with a group called Ultromics, which developed an algorithm that was trained on by the Mayo Clinic on a large library of their patients who have cardiac amyloid. Initially, we worked with them for automation of measurements, because I work at a cancer center where measurements have to be reproducible. Like, we can't have variability in our reports of the strength of the heart. And the problem is when echocardiography is more of an art than a science, and studies that have been published have reported that the general acceptable variation in reporting of ejection fraction between readers is up to 10%. But the problem in cardio-oncology is that the definition of cardiotoxicity is a drop in your ejection fraction of 10% or greater. And so our tolerance for inter-reader variability is consequently, it has to be lower, right? So I can't tolerate a 10% difference between me and my colleague. And so that's why we started looking at artificial intelligence solutions, because we felt like that would help reduce that variability. The company then pivoted into disease identification. They went from measuring different parameters within an echo to actually identifying diseases. First disease they sort of focused on was heart failure, and thereafter they moved on to cardiac amyloidosis. So we worked with our IT department and their company to set up a system where we anonymize the echo data and we transmit it up to a cloud, where it then gets downloaded and processed by Ultromics, and then we get a report back on every echocardiogram. These were the implementation steps that we had to go through. Probably the biggest issue is turnaround time, because in a busy echo lab, you want to be able to read your study as soon as it comes through, and you have to give it a few minutes for it to get processed. So we had to reduce that turnaround time initially, which was like 30 minutes, then it came down to 15 minutes. Now it's a matter of minutes. Like when I open a study, it's already processed. So over the course of a year, we processed close to 8,000 echocardiograms. If we looked at about 6 months of data to look at the amyloid component of this, and of 346 HFpEF positive patients, we found 15 patients who had cardiac amyloid. So we have consequently then changed our workflow. Before, there was a lack of clarity on which patients we should be referring for formal amyloid evaluation because there were so many risk factors that we would be examining. And now we have this one additional kind of more major criteria that we use, which is a positive report from the algorithm. And so when we looked at those 15 patients, 10 actually were known cases of cardiac amyloid that I already had in my clinic. However, 5 were patients that we didn't know about. So those were, one had already passed, but 4 of them were then referred to our amyloid clinic for further evaluation. So those patients were going to be worked up. I did have a case that we already knew about, but it's somewhat of an illustration of the technology. So this is a 78-year-old male with multiple myeloma who was referred for tachycardia. This is his echocardiogram. On this echo, I measured his wall thickness in multiple locations, and because he has myeloma, I'm looking for amyloid. I'm worried about amyloid in anybody who's referred to cardiology, even while they have a malignant hematologic disease. So his wall thickness was essentially upper limit of normal. It doesn't look like an amyloid heart. Ejection fraction is preserved. The only thing I can say off of this is, okay, well, maybe the atria are a little dilated, right? So the atria are dilated, but the LV looks fine. His GLS is about negative 16%, which is not that far off from normal. But okay, maybe there's a little bit of apical. Maybe the strain is a little bit better at the apex, so that raised some concern. And then when I looked at the diastology, there was some elevation in filling pressures on the left, so this patient's looking like they may have some HFpEF. On the right side, again, the pressures are elevated. So this patient has elevated filling pressures consistent with HFpEF. And because I do practice left atrial strain on most of my patients, I calculated the left atrial strain, which was markedly reduced. So reservoir strain should be around 35 to 40%. In this case, it was 14%. So significant reduction. Conduit and contraction strain should be closer to about negative 15%. In this case, they were negative 6 and negative 7.5. So this, in my mind, my suspicion for cardiac amyloid was pretty high, even though the LV walls were normal and the strain overall was normal. So we did a cardiac MRI because I felt like this patient warranted further evaluation. And we found that late gadolinium enhancement pattern was consistent with cardiac amyloidosis. There was also diffuse enhancement of the left and right atrial walls. So again, amyloid tends to deposit in more than just the left ventricle, and you can see that in this case. So in this case, because he has myeloma, you can't do a PYP scan. The PYP scan being positive is not going to tell you whether this is AL or ATTR. So you really need tissue. So this patient warranted a biopsy. We already had bone marrow. So we stained it with Congo red. That was negative for amyloid. So then we went on to do a fat pad biopsy. That was also negative. And even though, as hematologists will tell you, that the combined bone marrow and fat pad biopsy sensitivity is around 70 to 80%. So you really should catch AL in these 2 biopsy specimens. But it was negative, but my index of suspicion was quite high, so I wasn't going to let it go at that point. So we moved on to a target organ biopsy. We knew that the heart is where I was concerned about disease, so we did an endomyocardial biopsy, and that was positive. That tissue was then sent to Mayo for mass spectrometry, which confirmed AL amyloidosis in this case. So this patient then returns a couple of years later, now in atrial fibrillation. The walls still are not thick, okay? The walls are still not thick. The atria look about the same, except now the patient's in AFib, and perhaps as a consequence of the cardiac cycle that was examined, the GLS is now normal. It's negative 17%. You still see some apical sparing here, but now you can't read the diastology because the patient's in AFib, so I can't say anything about filling pressures. The TR velocity is now actually normal in this individual. So what happens here is, and I couldn't calculate left atrial strain like I did in the last case because now this patient's in AFib. So AFib is going to throw off, your atria is fibrillating. It's not going to demonstrate normal, or you can't reliably measure left atrial strain in this individual. So the AFib is masking the diastolic function. It's masking the left atrial strain. And I was thinking to myself, if this patient came to me now, I wouldn't have had any suspicion because they have normal wall thickness, they have normal GLS, they have normal pressures. And I probably would have dismissed the case. I would have felt like, okay, this is normal. However, we were running this AI now in the background at the time of this echo. And so it gave me this report at the end where it scored this patient as having HFpEF, even though I couldn't read the diastology, right? So I couldn't read the filling pressures because of the AFib, and the right heart pressures were actually normal at this point, but it's still called HFpEF with 100% certainty. So it gives a probability score of how consistent this image is. Ultralytics is trained on a 4-chamber view, so it looks at the best 4-chamber view, and it's matching it up to other cases of HFpEF and saying this is like 100% match. This patient has HFpEF. Then it runs the amyloid profiler on it and also says that this echo is suggestive of cardiac amyloid. So I felt like this is a good illustration of where it can really be helpful in some of these cases. So this overall has resulted in referrals from my own colleagues for suspected cases of cardiac amyloid that are more subtle because it's being called by the AI in the background. And then we do a quarterly review of all the positive cases, and then we refer these patients into our amyloidosis clinic for further evaluation. Briefly, I'm just going to review this one paper that came from Northwestern. They looked at a few different algorithms and kind of published their findings on the performance of some of these algorithms. So they looked at 4 different risk models. Huda's model is just based on medical claims data, so the electronic health record data and the ICD code data, and based on that, they developed a model to see what the likelihood of amyloidosis might be in an individual. And that's something I feel like it's pretty. It's similar to what we had done with our EHR. Except they're trying to run a probability score on these patients. And then Mayo developed an ATTR cardiomyopathy score, which looks at 3 clinical factors and 3 echo measurements. So they're looking at age, sex, and history of hypertension. And on the echo, they're looking at the ejection fraction, posterior wall thickness, and regional relative wall thickness. David Oyang from Cedars developed EchoNet LVH, which is a machine learning algorithm that looks at just the parasternal long axis view and the apical 4-chamber view. So that's similar to, so probably the 2 pure echo algorithms are Dr. Oyang's model and then the Ultralytics model that was trained at Mayo. And the Ultralytics model is looking only at the apical 4-chamber view. When they reviewed these 4 models, I kind of highlighted here the sensitivities. So the sensitivity of the Ultralytics model is the highest at 85%. The specificity is pretty good at 91%. The specificity of Dr. Oyang's model is higher at 98%, but with a lower sensitivity. So it'll miss more, but it'll be right more of the time. And that's resulting in a positive predictive value of 66%. Whereas the model that we use, we're going for not wanting to miss a case. So our sensitivity, we're using the model that has a higher sensitivity, but a lower positive predictive value. So only 1 out of 3 of those patients that are called positive will truly have amyloidosis within the heart. So these are a few of the models that are currently usable. And then Dr. Arsanjani is going to talk about some of the models that he's developed. Overall, we know that about 15 to 16% of patients with HFpEF and aortic stenosis have a TTR. And so that's a very high volume that is unrecognized in the community. And I feel that if all echocardiograms are evaluated systematically for potential amyloid, we're most likely going to increase the diagnosis, allowing for earlier medical intervention. And as AI advances, I think sensitivity and specificity for all these models is going to go up as the algorithms get smarter, essentially, right? And so adoption of AI in our practices is going to allow for improvements in overall patient outcomes and survival. And thank you.
Thank you, Dr. Jamal.